Good morning, everybody. I'm Adrienne Alfred-Burt, Executive Director of the Village Langley. For those who are not familiar with the Village Langley, we are a village-style community for people living with dementia and memory-related conditions. As today's participants will know, COVID-19 and the need to implement infection prevention and controls has added an incredible complexity to how we support people living with dementia. For example, enforcing social distancing measures and supporting optimal hand hygiene are posing significant challenges amongst people with cognitive impairment and disability. Restrictions to family visitation and the use of PPE further complicate a matter which was never straightforward to begin with. I'm very pleased to be moderating today's panel, Dementia Care During COVID-19, Your Questions Answered, and I'm really looking forward to speaking with today's panelists as they share their learnings and troubleshoot many of our questions that we all have as we operate care communities within British Columbia. So today, I'm very happy to be here with Julia Gill. Julia is an ethicist with Vancouver Coastal Health. I'm also here to welcome Kim Greer, and Kim is with Greer Dementia Training Incorporated. And we're also going to welcome Mariana Hudson. Mariana is the Provincial Coordinator of Education at the Alzheimer's Society of BC. And we also have with us Gregorio, who is a lived experienced expert, person living with dementia. So very special welcome to you, Mario. For those of you watching at home, you're welcome to use the chat pod to ask the panelists questions as we move throughout today's session, so I do encourage you to do that. And I'd like to begin by inviting each of our panelists to briefly share your key learnings. And let me begin with you, Kim.
Great, thank you so much, and thank you for all tuning into this. I know that a lot of you already know quite a bit about dementia, so I just wanted to sort of cover briefly to kind of set the stage for what we're having to work with and what we're having to deal with in care facilities. And the first thing that came to my mind for sure is how dementia doesn't just affect a person's memory, it's how dementia affects everything there is to about that person. So if I am having trouble with my memory, and I have a diagnosis of dementia, I'm also going to start having trouble understanding new information, understanding different objects and what they mean, and I interact with the world around me differently. So that, as Adrienne said, that alone is, sort of a challenge that we work with on a daily basis. And then you overlay COVID, which nobody has had experience with before. And then you've got, how do we hand wash? How do we keep people safe? How do we do all these things when it's hard for the person to understand and know what's going on around them all the time? So I think what we've sort of talked about is how you approach the person, how you communicate with them, and different ways to get the person to understand what it is that you're asking of them. It's really difficult to say to somebody with dementia, that's progressed in the disease process, to say, here's a mask, put it on, or here, let me put this mask on for you, and you come at them with the mask. It's really daunting for people. So there's probably a few different ideas that we'll get into talking about a bit later about how can I approach this individual in a way that will help them understand what it is we're trying to do. And then we'll also later on, I believe, touch on how can we help families be connected, because families are such a huge, important part of dementia care and being connected to their family members and loved ones. So just sort of wanted to lay the stage for people with dementia are understanding the world around them differently. It's a completely different ballgame now with COVID, and especially without families being able to visit in the ways that they did before. Thank you.
Thank you so much, Kim. I think that you've raised a really interesting point there, especially how you started your commentary talking about the word memory. And we so often hear the term memory care. as we hear about dementia. And I think that that can be such a confusing term for families when, especially within a COVID context, when we talk about helping people to understand the use of PPE and taking preventative measures when it comes to infection prevention and control. Memory is such a small part when it comes to dementia. And so I really appreciate that you mentioned that. That was great. Thank you. Julia, are you able to introduce yourself and things that you would like to discuss, things that you think are important?
Yeah, absolutely. Thanks, Adrian. And welcome, everyone. Thanks so much for being here with us. I'm going to start with a little bit of background of who I am and what I do, and then go into my kind of learnings and experiences during COVID-19 with people with dementia. So I am an ethicist or a clinical ethicist, and basically my job is to help to identify, analyze, and then resolve ethical issues all across the healthcare system. So at the heart of it, we're really a consultation service, and we provide that kind of decision-making support for difficult moral and ethical dilemmas to anyone across the health authority. So that includes doctors and nurses, allied health, healthcare leaders, but also the patients and their families. So as part of this job, ethicists from across the province have helped to support the COVID-19 response in a couple of different ways that affect patients with dementia. So we've helped to draft several of the ethical decision-making frameworks and ethical analyses for the Ministry of Health, as well as the BCCPA, and those are publicly available on the website, and I think will be shared with you with the material for this session. We also sit on the emergency operations centers and help to support leadership there, including the long-term care emergency operations center that I sit on. And we're available to individual teams for clinical consults for those specific on-the-ground issues that people are having. So I'll be sort of speaking from several of those perspectives. So throughout the pandemic, while doing this kind of work, one of my biggest learnings from an ethics lens specifically has really been that before COVID, we in sort of the Western world and Western culture put more of an emphasis on autonomy and the individual liberties and individual freedoms and individual rights. But now we suddenly have a little bit more of a public health ethic lens and a societal lens instead of that individual lens to tackle a problem. And that has significant effects on patients with dementia. A good example of this can actually be seen in one of the documents that was shared with you. So it's called Intervening When Patients or Residents Pose a Risk of COVID-19 Transmission to Others. And I just wanted to quickly share with you kind of the 6 ethical principles that we think about when working through issues in the care homes, in facilities, in the community, in patients who live at home. So the first one is the harm principle, and that's just the idea that society should protect itself from harm, and we should be trying to minimize the risk of exposure and spread. I think everyone agrees with that one. Proportionality is the options that we generate really should try to reflect the particular risks and the particular levels and be proportionate to the issue that we're trying to solve. The third one is procedural justice. So this is just the idea that we should be open, transparent, inclusive, accountable, and reasonable in our solutions, as well as consistent and transparent, especially with those communications that we have with our patients, with our residents, and with their loved ones, kind of like Kim mentioned. The next principle is the idea of respect. So that hasn't totally gone out of the picture. So whenever possible, we do try to uphold those individual liberties and that autonomy and say that that should be respected. And that also very importantly includes cultural safety and a trauma-informed care approach. We also say that solutions should be the least coercive and least restrictive as possible. And that has a particular lens with patients with dementia we can get into later. And the last principle is the idea of fairness. So the idea that basically similarly situated patients or residents should be treated similarly. As part of this, healthcare workers should also not assume that all patients are equally able to comply, right? Which of course we don't. Different patients are at a different place. Some patients or residents have diminished cognitive capacity, and that might affect their ability to listen, like Kim said, to remember and to actually adhere to those physical distance requirements that we're asking of them. And this really means that staff should be considering how to support those patients and residents and families on an individual basis. Fairness, I'll also add a nuance here, which is that the fairness requires that we appropriately respond to two different kinds of patients. The first one is those who are not able to comply because of that diminished or that altered capacity, for example, due to dementia, but also a variety of other reasons. And then those who are able to comply, but perhaps choose not to. And that requires a slightly different approach. So the ethics framework that I mentioned goes through sort of a step-by-step process of how to apply these principles to really bring the risk of harm to the individual, as well as that risk of the COVID harm to others and to society, down to what we consider a tolerable level. But of course, while still preserving the quality of life of people with dementia as much as possible. And we do this by putting in place an escalating degree of intervention, which I'm hoping to get into a little bit later. If you're interested, definitely I urge you to take a look at the BCCDC documents. But I'll just quickly end here with emphasizing that the key idea is really that we must look at patients as individuals and take into account each person's individual circumstances and really meet them and their families where they're at, especially when it concerns working with people with dementia.
Great. Thank you so much, Julia. I think ethics are always fascinating when we talk about ethics within the context of healthcare. And when we speak about persons with dementia, I can't wait until we get a chance to speak with Mario and hear his perspectives. And one of the things I think is so important to remember when we consider ethics in the context of persons living with dementia is that despite the fact that somebody has been labeled or determined to be legally incapable, it does not overwrite their legal decision or legal right to exercise consent.
Absolutely.
And that is a concept that is so often misunderstood and frankly completely forgotten about. And people always have the right to self-expression. And within an ethical framework, I think that is always something that we have to consider. And that's one of the reasons why we always have to ask ourselves, why are we doing something, for what reason and for what purpose and for what intention? So those are really excellent points that you've made. Thank you. Thank you. Okay, Mariana, really interested to hear your perspectives as an educator.
Absolutely. Thank you so much, Adrienne. And hello, everyone. Thank you very much to the BC Care Providers Association for having me be a part of this panel, and perfect timing as September is World Alzheimer's Month. My name is Mariana Hudson, and I am the Provincial Coordinator for Healthcare Provider Education at the Alzheimer's Society of BC. And one of the things that I'm responsible for is facilitating one of our workshops called Building a Strong Foundation for Dementia Care. And that is geared towards healthcare providers in all sorts of settings, whether they're care or non-care staff, and anyone that works with a person living with dementia, to ensure that they have that foundational knowledge in their work. So some of the things that I would like to share today are just stories, experiences from family members that we've heard, as well as from healthcare providers. There is no doubt that the pandemic that we continue to face has been challenging for everyone. And as you can imagine, and probably have already experienced firsthand, the challenges for family caregivers for people living with dementia have been extremely difficult. So just going to give you some examples. So for families supporting somebody living at home, we've heard that really that change in routine, it has had such a big impact on that person's day-to-day life. So not being able to access regular programming in the community, whether that's through an adult day program or libraries, or having limitations to those accesses, or limitations to having certain family members coming to visit because of keeping their bubbles safe, has led to changes. And some families have mentioned, we're seeing changes in dementia symptoms. We're seeing things like changes in behavior, excuse me, things like increased confusion or perhaps additional changes in sleep patterns. Those are some of the things that we've heard from families in the community. For families supporting someone living in the long-term care setting, of course, the family visitation changes in policy have had an extreme impact on people living with dementia as well as their family caregivers. One thing that really stood out to me from some feedback we received from family was that sense of lost time and urgency, knowing that time that is so precious with the family member to spend with, and now that they have the time back, which is wonderful, that time is now limited with having to wear protective equipment, which is understandable, but it changes that relationship and that ability to connect with somebody. From the healthcare perspective, we've heard, again, lots of experiences and stories through some of the surveys that we've put out to people. And really, from their perspective, we're hearing a lot of the same things and just being very difficult for them to actually see family members and their residents or clients, whomever they're supporting, go through these changes, seeing those loss in supports, seeing those changes in confusion, for example, seeing some changes in some of their behaviors because of the anxiety and the uncertainty of this pandemic. In addition, healthcare providers have shared just the sheer nuances of their roles, the change in their roles every day, having to do their regular day-to-day work, but also coming to work and having to adapt to these new situations, whether they're new practices or new rules that they have to also learn as they're going, all while, of course, trying to manage their own feelings about the pandemic. So lots of things that people are experiencing. I know these have been more of the challenging side, but we've also heard positive stories, and there are positive stories out there that are occurring, and those are the ones we do need to share. And things like family members, whether they're supporting someone at home, just finding creative ways of spending time together. We've heard about a couple that now takes these times to go out for drives together, something that they never really did before. They're finding more creative ways of spending time together. And that's going to the beach, sitting in the car and having a picnic, for example. Another story I heard was just the use of technology, bringing families together. For some, of course, technology has been a barrier, but for others it hasn't been. And it's actually brought families and other partners kind of together in this situation. Another story from healthcare providers that we've heard in that sort of positive lens is just having that ability to have that peer network, that support network with one another, sharing the experiences that they're having and the value of having the ability to speak to their colleagues and support one another in all this. So those are some of lots of stories, lots of experiences. Those actually have been what have taught me a lot about what's been the experience of supporting someone living with dementia and COVID. But the last piece I would like to end with is just mentioning or reminding people about the concept of person-centered care, which I know Julia and Kim have already talked about in their discussions. The best practice in dementia care, even during COVID-19, is still providing a person-centered approach to care. And that is simply putting the person first and the task second. So even though right now infection control and prevention policies have to be put in place, and understandably so, and they're very important to keep them in place for the safety and health of everyone, it's also important to ensure that those policies and procedures that organizations put in place are using a person-centered lens when they are putting those into or enacting them. So a very simple example is when there is use of PPE, providing staff with that extra time to spend to connect with somebody who might be having challenges with communicating. Or in another situation, if a person living with dementia in a care home setting is having difficulty following protocols, again, providing that extra time to problem solve with either family members or other colleagues to find the best solution for that individual. Could be a simple thing like putting a poster in the room, maybe with accessible language for that individual. Mm-hmm. So this may not always be easy, and I recognize that. It takes time, takes creativity, but finding the right approaches and sharing them can be very beneficial. Thank you.
So, Mariana, I think we might have just a quick minute left of your time. I'm wondering, do you have any advice from an education perspective? If we have, say, persons with dementia who are living in a long-term care setting or assisted living setting where family members do have limited access to visitation, do you have some suggestions for operators of those communities on how they might better educate family members on supportive practices for their loved ones living in those communities? Because operators of those communities have limited access, and means by which to do so. If you had one tip for family members or for operators to reach those family members, what would it be?
Well, I find that communication has been very, very important right now. What we're hearing from families is just not having that opportunity to connect with the operators. And there could, of course, each location is different, and there's a lot of different experiences here. So I want to recognize that there are probably lots of operators or locations that are doing a great job with that. But for the most part, that seems to be the barrier, the challenge. So I would just say simple techniques, either increasing phone calls to family members or on the website, providing more resources that way, just finding a way to stay connected to family members. And of course, providing resources that are already available in the community. And I will be talking a little bit, hopefully later, have an opportunity to talk a little bit more about our organization and some of the education that we have available. But connecting families to community agencies that already have that information available can be very beneficial.
Great, thank you. Great, thank you.
Thank you.
Now, Mario, very much looking forward to speaking with you. As a person living with dementia, I think everybody is really, really interested to hear your perspectives on best practice as we all adjust to our new normal of living with COVID-19 and how that affects the lived experience of people living with COVID-19, living with dementia, and then families and communities who are affected by it. So what are your thoughts? What would you like to share with us?
Thank you very much, Adrian. And I want to thank the BCCPA for the opportunity to be part of this forum. Hello, my name is Mario Gregorio. I worked as a data analyst and retired from TELUS, a telecommunications company 13 years ago. And a year later, I was diagnosed with vascular dementia. And if my neurologist from the UBC Brain Research Center is right, I should either be dead or worse, living in a long-term care facility, because he gave me a prognosis of 7 to 12 years. And yet, I'm still here, thanks to the medical care community composed of my family doctor, neurologist, geriatrician, cardiologist, nephrologist, social worker, and other specialists. And after I was diagnosed, I tried to learn as much as I can about dementia, and the news was not good. However, I decided to look at the positive side of things, and one of them is being an advocate to create awareness, reduce stigma, and help educate the public about dementia. Early this year, I was invited to join the CCNA Alzheimer's Society Canada National COVID-19 Task Force. It is composed of 8 teams of scientists and researchers to identify gaps in the delivery of care for people living in long-term care facilities. A particular damning report by the military exposed some of the issues that are very concerning for families and for people living in these facilities. And one of the issues identified is the inadequate training in the treatment and care of people living with dementia. Too often, they are treated as seniors, not as seniors with dementia. As we all know, dementia is a debilitating disease that has special challenges because its client is different from the next one. They respond in a variety of unexpected ways, depending on how far the dementia has affected their faculties. And there is no one cookie cutter manual or guideline that we can draw on to provide a level of care that is consistent with general practices. I am often asked on how do we look after people with dementia in a senior's home. And the answer is a simple one, and yet the execution of the task is complex and a very challenging one. To permit me to quote a phrase, the reality of a person with dementia is different from your reality. What do I mean by this statement? It is best answered by giving examples of incidents that may occur. A mother who a friend whose mother lives in a long-term care facility said his mother often calls him his daughter. She often looks for her cat, although it died many years ago. Although she is fluent in the English language, she has reverted back to her ethnic Chinese dialect. Occasionally, she would talk about going back to her room in her own house that my friend sold 4 years ago. The question then is asked, how do we respond to these issues without causing unnecessary distress or anxiety to the client? Do we correct the client or do we deflect the answer to prevent agitation or aggressive responses? I believe that with compassion and creativity, we can address some of the underlying issues. The COVID-19 pandemic brought additional challenges to my friend's mother in the long-term care facility because only one designated person is allowed to visit. He is not able to come, and his wife is the only person permitted to enter the premises. His mother feels abandoned because no one came to visit. This often caused her to yell and become verbally abusive to my friend's wife. My friend's wife was told that her mother-in-law does not want to wash her hands or use hand sanitizers before going back to her room. I believe a good question to ask is, why does she refuse to do the task? Or does she forget because of her dementia? It is rather unfortunate that most of the things we read in the media are about the indiscriminate use of pharmacology, neglect in the delivery of proper care, and horror stories of clients getting bed sores and unchanged, soiled, incontinent diapers of people in long-term facilities. A good number of caregivers come from the Philippines, and being a Filipino myself, it gives me pleasure whenever family members of people living with dementia recall the compassion and support for their loved ones at long-term care facilities. I hear stories about caregivers attending memorial services of departed parents. I also hear about caregivers attending memorial services of departed parents or caregivers sitting with clients and encourage them to tell slice of life story from their past. Allow me to end by saying that I think it is a good idea to put out good, heartwarming experiences from family members out in the public. And lastly, we need to engage and open a dialogue with people living with dementia and their families on their expectations from you. And according to Martha Stewart, this is a good thing. Thank you.
Thank you so much, Mario. That was really, really beautifully said, and I'm sure Martha Stewart will appreciate you referencing her work. I think you've raised a really interesting point there about visitation and the designated visitor, and how that concept is so difficult for both families and persons living with dementia who may be living in care communities and care settings. And I've often found, as an operator of a care community myself, that the designated visitation and that person, that concept and those decisions around that can be very, very hurtful and difficult for many families, because very often the preferred designated visitor that the family has is often incongruent with the preferred designated visitor of the person living with dementia, because the social and comfort attachments that the person living with dementia has developed are very often no longer their spouse or their daughter or their aunt, or it's somebody who their relationship has now developed and changed, and it's very difficult for that person's spouse or their daughter to accept and to understand, and the difficulties and challenges that can cause for families is insurmountable in some cases. And that's something that I'm very hopeful that some of our policymakers may come to realize, that although there may be, I think that there's a very good intention behind that policy and that directive, that there's a familial and relationship impact to that can be quite damaging. So thank you for raising that point. As somebody with lived experience, I think it's very important. So thank you. Okay, so some discussion questions that have come about that I open to the entire panel. So I'd like to know if anybody is brave enough to take on a question around PPE, so personal protective equipment. So when we look at things like masks, the dreaded mask that everybody has just become so uncomfortable with now, with the itchiness and the mask acne and the rashes. Masks, gowns, we know that these things are necessary, but these measures can be very confusing for people living with dementia. So is anybody willing to take on the question of what can we do in public and in private settings to help minimize confusion for persons living with dementia? Maybe Mario and Kim. I think Kim and then Mario, I think, would be great people to answer these questions.
Mary, do you mind if I go first? My thought on that is, so as we've been talking about how caring for somebody living with dementia we need to be person-centered. And dementia care is all about relationships. And you build a relationship by communicating. And if I cannot communicate with a person living with dementia, and I'm their caregiver, and if I don't understand what they're saying back to me, then I can't build a relationship and I cannot care for this person adequately. And so a couple of the panelists have mentioned getting to know the person and getting to know who they are and what makes them happy and what doesn't make them happy and what they're used to. So some of the suggestions for, does it have to be a mask? If I am a person who always wore elegant scarves, could you get a scarf and say, hey, Kim, let's put this scarf on and go out for a walk? And maybe it's something that I'm much more familiar with rather than somebody, again, saying, here's a mask and put this mask on. One thing that I've heard some good things about are the clear masks, which people with dementia, living with dementia, tend to get to the point where nonverbal communication is so incredibly important. And being able to see facial expressions, smiles, that kind of thing, that alone can convey what I'm trying to say without my needing to say anything. So those are just a couple of my thoughts.
Great. Thank you, Kim. Thank you. Mario.
I think Kim's suggestion about the scarf is a good idea, because from experience and having seen some of these people with dementia being asked to wear masks, they sort of very reluctant to use it, because I myself feel like it's very difficult to breathe with these things. I have quite a few of those, and to me, really, they are very inconvenient, but I have to use it when I use the SkyTrain or for the bus, because here in British Columbia, it is required, it's mandatory. So I think something similar to a scarf that Kim mentioned is one of the best way of doing it. And another thing that comes to mind is, if they are not able to wear the mask, make sure that they are safe, in a safe distance from one another. I do have family members that visit me, but I do not allow them inside my house, and we do our communications, our family together in my backyard, so that there is enough safe distancing from everybody. Thank you.
Mm-hmm. Great. Thank you. Thank you. So
Just,
now we've, oh, I'm sorry. Go ahead.
I just wanted to follow up with a quick point about that. With the distancing, nobody likes to be told what to do, period. And if I come in and I'm like, hey, 10 people in this room, you all need to social distance. So you come and sit over here and you come and sit over here, as opposed to, rather than telling the person what to do, it would be, come this way, come and sit here with me. And sometimes just that simple approach and the simple changing of the words can make it much easier, because I'm not telling you what to do. I'm asking you to give me a hand over here. So thanks.
Yeah, and invitational suggestion, it can make all the difference in the world. Yeah.
Adrian, could I just add one more thing?
Yes,
I love
yeah.
the conversation, and I'm just picking up on some things. What Kim just said exactly, involving the person to participate in something. That's exactly what I was thinking. Just from the healthcare provider perspective of when they're putting masks on, and I'm kind of going back to some of Kim's comments already, but really the importance of that nonverbal communication, and really understanding when you are wearing that mask and how much it's covering your face, and you're not really able to communicate with just the words anymore, because the mask's muffling those words. So really encouraging healthcare providers to try speaking to a mirror, having a look, or in front of a colleague, and see if people understand what you're saying when you're communicating with the mask on, because it can create that barrier. So being mindful of your body language, using your hands and gestures, and a lot of facial expressions to communicate. And last tip, one thing that I've heard from a lot of different care home communities is success with wearing name tags with photos on them. There are other ways to kind of still connect with people and avoid that confusion that creates when you're creating that barrier to providing care. So having a nice name tag with a big name, the photo on it, so they recognize the person's smiling face in that photo. So then they perhaps might trust the individual a bit more to come into their suite and engage with them. Thank you.
Thank you, Mariana. Yeah, and then good point. And I think if we do, if we are wearing the face covering mask, I think one of the things we really have to consider too is you have to use really exaggerated facial expressions so that the expression shows in your eyes, right? Almost like you've had that really bad facelift, the Hollywood facelift, so you can really see it in your eyes, because otherwise they have no idea what's going on behind the mask, right? So. Okay, so lots of great discussion around long-term care, assisted living communities, sort of, congregate living settings. But what about the specific challenges that are coming about in home health care? Any thoughts on that? How is COVID-19 affecting dementia support that actually takes place in somebody's home?
So I can maybe start with that
Julia,
one and just say, in the consults that I've experienced with people who are supporting their loved ones at home who have dementia, it's a common theme, but just exacerbated, which is caregiver burnout, dealing with COVID-19 and the lack of ability to maybe go outside for walks, or like one of the other panelists was mentioning, sort of engaging in those habits and those routines that people have gotten used to, is difficult for the person themselves, but extremely difficult on their caregivers as well. So caregiver burnout has been a theme that I've seen in a lot of my consultations.
Definitely. Any other comments about home health care?
I'll add to that. In addition to the caregiver burnout, and it's so wide, that area. It's looking at supporting that individual in the home when those supports were not available, as Julia mentioned, but also just taking on new responsibilities. Just the thinking about grocery shopping, or thinking about managing appointments in this new world of virtual care and other things. So adding those additional challenges and navigating that system kind of adds to that, the idea of caregiver burnout. Some other challenges that we've heard from families was, especially at the beginning, and it's still continuing, but very much at the beginning, when we were just trying to understand a little bit more about what COVID-19 was, how it was being transmitted, was a lot of fear of having and welcoming home care workers into the home. So a lot of the similar challenges experienced in long-term care about receiving somebody wearing a mask and a gown into their home in that context, same situation in the house. The additional challenge, though, of course, is families not feeling comfortable having people come in, added to the additional tasks that they had to take on. So creating that additional caregiver burnout, definitely. And I'll also add, just from the healthcare provider perspective, their additional uncertainty as well, managing this from the healthcare worker coming into the home and having to ask additional screening questions, and kind of adding, as I kind of alluded to earlier, adding a bit more things to their day that they weren't quite used to. So considering that as well.
So we've really got a perfect storm here. We've got caregiver burnout. We have introduction potential of unknown people into your home and potential risk of infection. We have home care staff who are concerned about, you know, them contracting infection. And then we have strangers being introduced into the homes of a person living with dementia, and fear and stress that causes them. And then we're in a labor shortage of home care staff. So, you know, we're kind of stuck. So yeah, not a great situation. Okay, so next, one of my favorite topics, very near and dear to my heart, restriction of movement. So freedom of movement of persons with dementia, freedom of movement of anybody is a major issue, but particularly when we talk about ethical decisions and ethical decisions around restriction of movement of people living with dementia. How can care providers work with families most effectively to ensure that people's movement is not impaired, that it is not restricted, that people can still have free decision to move their bodies in a way that they need to? People with dementia, with many types of dementia, physically move as an outlet to move their bodies, to release energies and manage symptoms. How can people work with families to ensure that that can take place in a safe, healthy manner to help manage the symptoms and their disease? And how should we be engaging persons living with dementia to make sure that that can still happen, regardless of what type of setting they're living in? What can we do? I open this up to anybody.
So maybe I can start. First of all, thank you so much for asking this question. It's such an important question from an ethics perspective, and from like the caregiver's perspective, the patient perspective, and family perspective. And I'll try and keep my comments as brief as possible, because I'd really like to hear about the specific creative solutions that my panelists have. But I guess just from an ethics perspective, when we're intervening to reduce that risk of harm down to a tolerable level, absolutely, as part of an ethical lens, we have to include the family, we have to include the team. It has to be a transparent process, and we try and sort of employ that process to come to a trauma-informed and recovery-oriented and relational approach. Those are really key, and I think using sort of some of the specific strategies that some of my panelists have mentioned, we can try and do that, but it's really through that open an honest conversation with the family members that really starts that. The key is just that for that communication with family to be clear, for it to be consistent, for it to be effective, so that it's understood on both sides, and also to have sort of a reasonably frequent amount of communication with families, right? Obviously, within our sort of strapped resources, to be able to do that as much as possible is such a help to the family, is such a help to the resident, to engage with them and to help sort of manage those expectations and really try and put everyone on the same page with respect to the family. Now I'll just sort of briefly talk from the resident perspective. We kind of laid out in the ethical decision-making framework that I mentioned just the idea of an escalating degree of intervention when restricting that movement, or stopping someone from going outside, or whatever it may be, because we don't want to do that. We don't want to default to that. But we try and put in place the least restrictive measures that can possibly be implemented, balancing the safety of the individual and their community from a COVID-19 transmission perspective, while trying to maximize their quality of life, right? And that is a difficult balance to achieve. But we've kind of laid out a process that I'll just very briefly say, and then hopefully we could hear from the other panelists, where, of course, again, each case has to be examined from its own specific circumstances, that family's perspective, that patient's perspective. But we first consider implementing sort of environmental perspectives. So I think it was Kim or Mariana mentioned having signage and sort of words that are more clear to the resident and in words that they can understand around maybe some restrictions or areas they should or should not go. Some facilities have placed people at entrances and exits just to sort of remind people of appropriate behaviors, right? So we start with those environmental interventions to try and guide and direct, but maximize the amount of movement and the amount of autonomy that the individual can have. Next, kind of if those don't work, then all efforts should be made to, well, this is probably first, this is throughout the process, that effort should be made to really understand why the patient or resident is not complying, right? I think Mario spoke to that about figuring out what is going on there and then try to educate and inform and encourage them to participate. And that can go for the family or the resident. And depending where the resident is at with their disease trajectory, that may or may not be effective, but certainly worth trying. And then considering all those creative options that my fellow panel members have mentioned, right? To try and meet those individual needs, to find out about the individual and come up with the creative solutions. These may be comforts such as access to entertainment or like non-standard interventions, things we wouldn't usually try, but let's get creative and sort of figure out how we can meet the person where they're at to sort of use that redirection or that distraction and engage them to increase their quality of life, but keep everyone safe. We want to maximize the ability to move, like Adrian said, and to go outside, but in those situations where maybe we can't, how do we preserve that quality of life, right? That's what we look at from an ethics perspective. And then if none of these things are possible, within facilities, we're looking to maybe cohort residents, put people together who have similar interests and maybe who are taking similar risks, right? And that in that way, we can sort of reduce the risk of transmission to other residents. I also want to recognize that many of the patients and residents really live with the trauma and the restrictions on their autonomy, and that can be re-traumatizing. So I often get consults about restraints. So that could be physical restraints or chemical restraints or environmental restraints. And I guess I should just stress that using those should only really be a measure of last resort. We don't want to resort to that. There's a lot of other steps you could take. I'd urge you to take a look at the ethical decision-making framework. And if you do reach that point, to only use them in accordance with like healthcare authority policies and to speak to your MHO, your medical health officer, about kind of what are the other options that you can try. So with that, I guess I'll end and just to hopefully hear from the other panelists their creative solutions around how to approach that, the solutions within that ethical decision-making process.
Great, thank you, Julia. Mario, see your hand raised.
Thank you. Something that I just thought about is the creative redesign of the environment. So
Yes.
Probably these facilities can think of how do we cluster this common areas so that there's enough distancing, because something that comes to mind is the short-term memory losses of people with dementia. They may want to comply, but because they forget, they probably will not occur to them what they should be doing. However, if we provide an environment where they can be safely distanced from other people, looking at cafeterias or probably the gardens, maybe we can have cluster designs wherein there's enough sitting areas away from other people. Thank you.
Mm-hmm. Thank you, Mario. And I think, as operators of care settings, most care settings, if you think strategically about your space, you can naturally create cohorts, or as for those of us who do not live in a care setting, your bubbles. What we would call a bubble, you can create bubbles. Now, they may not be a bubble of 6. We have to be realistic about some of the age of buildings and settings. We do have to think realistically, but you can create some degree of cohorting with some, with some balance of creativity. Kim.
I just wanted to add on to these great comments that are being made. I keep coming back to good dementia care is about relationships. And if I can't take free will away from a person. Everybody has, and I'm so glad, Adrian, this is a hot button for you as well, is everybody has the right to a self-determined life. And you can never take free will away from somebody. And we're already using environmental restraints in a lot of care communities with the memory care units that are already secured and locked. So it gets down to, okay, if these are the environmental restraints we already have and we can't take away free will, then what does it come back to? It comes back to the relationship that you have with the person that you're taking care of and how much you can find out about them and how much you know about them to be able to help them through their day. So one example I'd love to use is, years ago I worked in Chilliwack in a care community, and we had this one gentleman who every day around the same time, maybe about 10:30, 11, maybe a bit earlier, about 10 o'clock in the morning, after he had his breakfast and his coffee, he would head out into the garden, which was great. It had a big, huge wall around it, but he would climb the wall and do his best to keep on going. And so everybody started to think, okay, well, maybe we can, make the wall higher. Maybe we can put something in front of the where he usually goes, like a bench, or not a bench because he'd climb up on that, but something else to restrict, him from getting up there. But the important thing is, sure, you can do all of these environmental things and things around the person, but who is this person? Why is he doing this? And I think Mario talked quite a bit about that. So if dementia care is about relationships, and relationships is built on communication, I need to figure out who this person is. So the reason why this gentleman was always heading for the door at the same time is that he had owned a horse ranch. And every day after breakfast, he would go out his back door, climb the fence to the paddock, and spend the rest of the day out there. Mm-hmm. So he goes from somebody being, he's the resident who's wandering and trying to elope, to a guy who's just trying to live his life. So if you're trying to help social distance people, focus, it might be really helpful to focus in on who is this person? What is it that I can help them with to continue to feel like they're part of this community in a way that they'll understand? So if I was caring for each of you on this panel right now, and each of you were heading for the door, I would want to know as much as I personally possibly could learn about you, so I could approach each of you differently and say, oh, Jessica, I know Jessica loves gardening. Do you want to come this way with me down the hall, and we can look at those flowers? And with Mario, he takes the train every year. He likes to take the train, so maybe he likes trains from his past, so we can talk about that. Again, a lot of it comes down to relationship based and knowing the person, and then being able to help support them based on who they are, getting back to this person-centered care.
Thank you so much, Kim. You know what, you touched on another, we know each other, and you know some of my hot buttons. One of my other hot buttons is language. Big thing with language. So I've noticed throughout the course of the conversation, we've stopped using the F word, which is facility, and I think I've heard more of the C word, which is community, coming about. So thank you. I've noticed that. But Kim, another word I cringe when I hear people say, and we hear it so often, especially on assessments, is the word exit seeking. And so many people are not exit seeking. What they're doing is, they're leaving at a certain time because in their mind they're going to repeat a lifelong pattern and behavior that serves a meaningful purpose for them. They're not trying to leave your care community because they're being non-compliant. They're going to work. They're going home for dinner because their wife is going to be upset with them if they're late for her roast beef dinner. They're doing something with a purpose, and it's our role to understand what purpose or meaning are they trying to serve. So
and it's not
that's
behavior.
Good care.
There's another word. There's a reason. Behavior, because they're not behaviors. It is a person with dementia living their life. It is not a behavior. And I think,
thank you.
COVID or not, we have such a responsibility to treat people like people. And our system has really not helped us with that over time, because we have, I'm going to stop talking soon because this is really another topic, but when you start to focus on the individual as a person, rather than, throwing the mask up and saying, here, put this mask on. Well, maybe I worked my entire life as, a mason, where I had to wear a mask all the time, and I hated it because it meant work for me. So it's not a behavior, it's a person. And changing those words and changing how you interact with an individual living with dementia can, it goes from being a caregiving relationship to we're kind of all in this together and let's all help each other out because it's tough times for everyone.
Perfect. So what has
Absolutely.
happened is exactly what I knew was going to happen. We've turned into a conversation that would have been great over a bottle of wine, and we have 5 minutes and 52 seconds left. So we're going to cut it down to one remaining question, and we'll give everybody 1 minute. Everybody 1 minute to weigh in. So I think the most important question that is left is, how did we forget the bottle of wine? Which is obviously an important question, but isolation. Okay. So in terms of the isolation that people living with dementia, and then the isolation that the staff who are supporting them are feeling, because I can tell you, the staff that are supporting persons living with dementia are doing an amazing job. These guys in every setting, they go to work, they're working long shifts, and then they go home. They're not going anywhere else. They're also isolated because they are terrified of introducing an infectious pathogen into their place of work and putting these people at risk of infection themselves. So the staff are feeling equally as isolated as people living with. So as operators of care settings, and then as educators and ethicists and people who support them, what would you like to say? Do you have any advice to help reduce people's isolation? So Julia, let's start with you. 1 minute.
Oh gosh, it's a tough question because it's affecting all areas of our life, COVID, right? Like you say, I think our healthcare workers are doing an amazing job of, like you say, going to work and then going home, and that's kind of it, right? Because they're really thinking about their sort of feeling of a moral obligation or their ethical duty to take care of their patients. And by sort of going out into the community, they might be exposing themselves to that risk and then exposing their patients to that risk. So I guess I would urge those care providers who are taking such good care and are sort of isolating themselves for the good of their patients to really spend time taking care of themselves within their bubble, talking to the people who are the important support people within their bubble, and spending time on what supports their mental health, their hobbies, they're taking time off work and just recharging their own batteries, because it's taking such a toll on everyone. And in order to come to work and, do the amazing work of, like we've been talking about, finding out who the patient is and communicating with the family and understanding why certain things are happening and finding those creative solutions, you have to recharge your own battery. Mm-hmm. So however you can do that while staying safe within your bubble and your support people, spend time and spend effort doing that.
Thank you. Thank you very much. Mariana.
Yeah, I was just thinking about that. That's wonderful, Julie. I think that's exactly some advice that I would give as well. And just on that particular topic of recharging, and also, Kim mentioned, everyone mentioned the importance of relationships that we talk about. Dementia care is about relationships. I really like how you said that, Kim, earlier. And we, as Julia mentioned, the fact that staff are spending that extra time and are seeing the residents that they're supporting, whether it's in home care or in long-term care, feeling isolated or looking isolated, appearing isolated. Some might even be feeling lonely. There are those experiences of loneliness, and we know the impact that loneliness can have on people's health and well-being. So within that context, I just want to just briefly mention, for operators who are supporting their staff with finding ways to recharge, the Alzheimer's Society does have a resource on dementia and staff grief. And this is a really relevant resource to bring up in any opportunities that you have with education. And I realize education might not be the biggest priority right now as you're supporting your staff and dealing with staff shortages. There's a lot of things happening there, but finding those tidbits of moments in your day, whether it's through a safety huddle or at shift change, those opportunities to have those moments to talk about these issues that they're experiencing, that they're seeing in their residents. And then for the actual residents themselves, there are no quick and fast solutions to this. It's finding creative ways, especially for those residents that don't actually have any visitors. Mm-hmm. I do think about those people that don't have people who are designated because they might not be connected. So are there ways to connect them to virtual visits? And if they haven't already done so, maybe increasing that, finding volunteers in the community that can support them. And of course, the staff just continuing to ensure that they're checking in with their residents and looking out for those signs of feeling withdrawn and loneliness, and not and attribute it to other needs that might not be met in that moment. So I don't know if
Thank
that
you
was a
so
minute, but there
much.
we go. Thank you.
No, that was a beautiful answer. And there are certainly some residents who do not have visitors, and it's absolutely heartbreaking. It's heartbreaking.
Yeah.
Mario, your thoughts, 1 minute.
I like Julia's suggestion of creative solutions because sometimes we may not want this sort of close contact with the residents. So how about trying to implement certain ideas like them sitting by the window and the and their family outside, and they can talk with each other. I also encourage the idea for people like myself, which I have implemented with my grandchildren, is what I call the drive-by hugs, wherein they sit in the car and I am standing in the by the sidewalk, and then we just chat and we do the ASL hugs of trying to greet each other and just showing how much we love them. And lastly, one of the things that I have sort of implemented with my family and friends is I give them gift cards to go to certain stores like Tim Hortons or Starbucks, and then we purchase take out package paper bags, and then we eat with safe distancing in my backyard. Thank you.
Wow. Well, thank you, Mario. I would love to come for a picnic at your house anytime. Anytime. And with that, we are out of time. We are completely out of time. So I would love to thank our panel today. I think this was a great discussion, and I would love to meet with you guys again anytime. So thank you very much. Excellent conversation.
Thank you.
Thank you.
Thanks, everyone.
You're all awesome.